I'm Dr. Janice Williams, and this lecture is part two of a neurology lecture where we will be talking about some brain injuries and the disease process that may occur related to an injury to the brain. I recommend that you read in your textbooks content related to brain injury and then also look at your guidelines book that was recommended that you would be able to assess what are the guidelines that direct how we should be treating patients who may present with brain injury. So let's get started talking about brain injury. When you think about injury to the brain, I want you to think about the mechanisms in which they occur. We're going to start by talking about acute brain injuries. When you think about an acute brain injury, there are several ways in which that can happen. It can be actual trauma to the area, to the brain. It could be ischemia. It could be edema, vascular failure, and reperfusion injuries. All can be mechanisms of acute brain injury. We categorize acute brain injury into two primary categories, which is primary and secondary. A primary acute brain injury occurs immediately at the onset of the injury. So you start to see the manifestations of that injury immediately following the trauma. Secondary injury is when there's a development and further neurological damage, which is subsequent to the primary injury. It can happen within days or weeks. And what we know that we get a change in the ATP levels, which thus can lead to necrosis and then reduced permeability of the membranes. When you think about cell injury after a acute ischemia, I want you to think about it in the form of this algorithm where you have the ischemia, you're going to have some cell hypoxia, then the mitochondria will fail, right? And when you get that, you're going to have a decrease in the sequestration of the calcium or even the decrease in the ATP. And when you start to have these decreases, what we know, it leads to cellular death, right? And we have a failure in reperfusion, which thus causes the changes that we may see in our patients. So what are some of these clinical manifestations that you may see when a patient presents with a brain injury? Their level of consciousness can be changed. They can come in talking about headaches, and then they can also talk about visual disturbances. There are assessment tools out there that you can utilize to evaluate and screen the level of consciousness of your patient, also known as the GCS assessment. So let's kind of go back a little bit and talk about the diversity of mechanisms that impact the brain and cause injury. We're talking about issues such as a stroke, it can be tumors, it can be infections, and even seizures. So how does a global brain injury manifest itself? It manifests itself with alterations in both the sensory and the motor functions. These patients usually have a change in their level of consciousness, and it can be in a stepwise process in which it occurs. So you think about the areas of the brain, right? And then you think about how it impacts, that injury would impact that area of the brain. So you can have problems even with things such as their eye movement reflexes that can also be seen in these patients. It highlights the importance of doing a good neurological assessment on these patients. If you have a patient who has hypoxia or ischemia injuries, this means that they have a decrease in oxygen and the perfusion, which is needed to maintain the ability of the brain to function. They also experience ischemia. This is when the brain blood flow is reduced or interrupted, and then they have that focal cerebral ischemic, such as the stroke, where it happens in a specific area. So when you think about the brain, I want you to think about the things that can occur, such as headaches, concussions, confusions, the nausea, the vomiting. There's so much that can occur when the patient has a brain injury. Let's talk a little bit about concussions. We're starting to see more individuals who may experience concussions because if you think about individuals who play sports, these patients can talk about headaches that do not go away, right, after some type of trauma. And what we can see is that sometimes they can have changes in the way that they play and interact with others, all as a result of concussions. They can have a loss of skills and abilities in performing daily tasks, and even things as simple as walking. Furthermore, when you think about concussions, you're thinking about there was a some type of force, right, that occurred to the head, and it resulted either indirectly or directly with some type of trauma. And that trauma or that actual impact could be to the head, the face, the neck, or it could be anywhere else that it can occur. These may be patients who present, we're saying maybe they fell and hit their head. So it's important to do a good assessment on these patients and asking them the appropriate questions and screen these patients. So, how do we grade a concussion? It's graded on a scale of 1, 2, or 3. As you can see here on the slide, a grade 1 concussion is when they have transient confusion, they have no loss of consciousness, and the symptoms or the mental status changes, they usually occur or resolve in less than 15 minutes. That's a grade 1. Grade 2 is they also can have that transient confusion. They have no loss of consciousness, and their concussion symptoms or their mental status abnormalities on examination last more than 15 minutes. Whereas the grade 3, they have that loss of consciousness. It can be for seconds or it can be prolonged. So grade 1 and 2, no loss of consciousness, and the difference is the time in which they regain their ability to come to, in a sense, perform normally. So what is post-concussion syndrome? Because that does exist. That is referred to as an immediate and transient loss of consciousness, accompanied by a brief period of amnesia, and it happens usually after a blow to the head. The recovery usually takes about 24 hours, and their symptoms can be mild and they can persist for months. I have included in these slides some videos that you can go to where you can learn more about concussions and how to evaluate them, how to treat them, and what the patients may present like. So let's talk a little bit about traumatic brain injury. This is categorized according to the severity, location, and injury. Severity is based on the GCS score on admission to the hospital, the lowest score in the first 48 hours following the admission. The injury severity and outcome are dependent on the physiological state of the brain. So when you think about traumatic brain injury, it's an alteration in the brain's function or other evidence of brain pathology caused by an external force. Males have the highest incidence in every age group. Most common causes are falls for children and older adults by unintentional blunt trauma and motor vehicle accidents. Advancement in safety measures have decreased incidence of TBI, traumatic brain injury. You can have primary or secondary, okay? Again, primary, direct trauma, a direct impact, and then secondary is that impact that occurs subsequently. Here you can see the types of traumatic brain injury that can occur as based on primary and secondary. You can have closed trauma related to traumatic brain injury, and then you can have open. Closed is also referred to as blunt, and open is penetrating. Closed is when the head strikes a hard surface or a rapidly moving object strikes the head. The dura remains intact, the brain tissues are not exposed to the environment. Whereas an open penetrating trauma is when the injury breaks the dura and exposes the cranial contents to the environment. I referred to the Glasgow Coma Scale in the previous slides. Here you can see how to rate and how to utilize the Glasgow Coma slide. Take a few minutes to pause this lecture and look at how we rate it: mild, moderate, and severe. It is based off of the scoring of this GCS screening tool. We can classify our primary brain injuries into two categories. It's either focal or diffuse, right? So a focal is it affects one area of the brain, and diffuse affects more than one area of the brain. It's just as it sounds. You can also have coup injury, where the injury at the site of impact, that's exactly where the head was hit, and that's where you have the injury. And then you have contra coup injury, and that is the injury to the brain from rebounding or hitting the opposite side of the skull. If you look at this animation here on this slide, you can see where coup would be. If you fall back the area in the posterior aspect of the brain, that would be coup. The contra coup would be the residual from the head being bouncing back and forth, that you would have trauma or injury to the contra coup area. More on the focal brain injury is the force of impact typically produces contusions. The manifestations usually is when they have a loss of consciousness. So how do you treat it? We want to control the intracranial pressure and possibly surgery. So this is not something you would do as a primary care provider, but you do want to make sure that you're assessing your patient if they come in and tell you that they've had a brain injury, that you're doing the GCS screening on those patients and referring appropriately. So focal brain injuries, also you can get your contusions, which can cause hematomas. You can get subdural hematomas and intracranial hematomas. So how do you treat a TBI? We want to make sure that they are cardiopulmonary stabilized. You want to do your radiologic screenings of the brain. You want cervical decompression. That will be what your neurologist may do, but you as the primary care want to make sure that you are doing the appropriate screening if necessary. Oftentimes, you may not be working as a family nurse practitioner in an emergency room. So what you may want to make sure that you pay attention when you're assessing your patients, looking in the appropriate areas for possible complications related to a traumatic brain injury. If you look at these images, you can see that the patients may present with discoloration or erythema or hematomas around the eyes and behind the ears. So doing an appropriate assessment of your patient is going to be very important when you're screening a patient for a traumatic brain injury. Asking the right questions, but making sure you take the time to do a thorough assessment of these patients. I have further added some links where you can get more information about traumatic brain injury. There are also times when you may see, when we think about neurology, I want you to also think about the spine. It is important that you remember that the spine is part of the neurological system. And I am not going to go over these slides because this would be information that you should remember from pathophysiology about what does the spinal column consist of. So we know we have our cervical, our thoracic, our lumbar, our sacral, and our coccygeal. So there are many causes, again, for spinal cord injuries, things such as falls, motor vehicle accidents, sports, and they can lead to either complete paraplegia or incomplete. We can have primary spinal cord injuries, and we also have secondary spinal cord injuries. Primary spinal cord injury is the initial trauma that occurs immediately following the tissue destruction. Whereas secondary is the cascade of vascular, cellular, and biochemical events that occur after. This can be just a few minutes after injury, or it can be weeks after. You can see things such as microscopic hemorrhaging, edema, swelling. So it's important if you evaluate a patient for a spinal cord injury that you also educate the patient of symptoms to monitor for, because just when they present in your office, they may have none of these symptoms, but they may occur. And if they occur later on, they need to know what symptoms to monitor for and what to do if they do actually feel like their neurological system has been compromised, and know how to follow up in the emergency room immediately. There is also the chance of spinal shock. This is when there is a loss of continuous tonic discharge from the brain and the brainstem. And this leads to inhibition of the suprasegmental impulses. So what does a spinal cord injury look like if it's neurological shock? You're going to have the vasodilatation, hypotension, bradycardia, hypothermia. And as you know, Dr. Williams is a stickler for making sure that I highlight and express to you all the importance of doing a comprehensive assessment on your patients when they present for any disorder, but especially a neurological. So, what does it look like to say someone may present with spinal shock or neurogenic shock? A spinal shock, complete loss of reflexes. They may have flaccidity or paralysis and sensory deficits. Whereas neurological shock, it occurs in the cervical and upper thoracic cord injury, and it can be caused by the absence of the sympathetic activity from loss of supraspinal control, unopposed parasympathetic tone mediated by the intact vagus nerve. So when you think about autonomic hyperreflexia or dysreflexia, it's a syndrome where you have sudden massive reflex sympathetic discharge associated with a spinal cord injury at the thoracic level of T6 or above. They get imbalance in the presence between the sympathetic and parasympathetic nervous system. These patients may manifest with their hypertension, bradycardia. They talk about a pounding headache, blurred vision, sweating above the lesion or flushing skin, and they can talk about nasal congestion and nausea. If you listen to these symptoms, these are very common symptoms that patients can present in your office for many different things. So making sure that you do a thorough assessment of if they've had any type of injury to the spinal cord is going to be important. How do you treat these patients? You elevate the head of the bed. Stimulus should be found or removed. So if there's anything that's stimulating the nervous system, you want to try to move that. And these patients may get topical nitroglycerin paste to level the lesions. This may not be something that you do in your office, but it's important for you to know that this is how they will be treated. So here I just wanted to present you with a slide which is a visual for what a normal spinal cord process looks like compared to a autonomic hyperreflexia. So how do you treat it? Immobilization, decompression, corticosteroids, therapeutic hypothermia. What I want you to know is this is an emergency. So if you have a patient that you feel has had a spinal cord injury, these patients are going to the emergency room immediately. If these patients are present to your office, you will be calling 911. As a nurse practitioner, your job is to ask the appropriate questions, do the appropriate assessment, and then get them to the appropriate emergency care. That concludes this lecture on spinal cord injuries and traumatic brain injuries. This is just an overview to kind of give you an understanding of what may occur if a patient presents in your office with a traumatic brain injury, or talk about even possibly having a spinal cord injury. They may not say, I had a brain injury. They're definitely not going to say I had a spinal cord injury. These are individuals who will present to your office who said that maybe they were playing a sport, they got in a motor vehicle accident, and they're coming to you for an assessment. It is your responsibility to ask the appropriate questions, do the comprehensive assessment, and to refer accordingly. This concludes this lecture, and then we will move to part 3 of the neurological lecture.